This section of our training is examples of more common OB/GYN point of care ultrasound situations you may encounter with your clinic setting, triage, inpatient, outpatient. Most of them are going to be non-urgent since we talked about the more urgent situations in the triage section. Case study number 1. Person comes in, first baby, early pregnancy assessment. It's a new OB visit at your clinic, history of irregular menstrual period. Approximately 2 months ago was the last period. Noted a recent positive pregnancy test. Wanted to get checked out. Has a report of mild lower abdominal discomfort, just generalized, and then no vaginal bleeding. Ultrasound, you attempt to do a transabdominal ultrasound, but because she's less than 8-9 weeks gestation, you're not able to visualize things well. Her bladder wasn't full, and you switch and pivot over to a transvaginal ultrasound, revealing that the intrauterine gestational sac measures approximately 6 weeks gestation. There's no evidence of a fetal pole or cardiac activity. The ovaries look normal, no gross anomalies. Based on these findings, you have two things. You can consider early gestational age, just can't see and confirm viability, and recommend repeating an ultrasound, doing serial HCGs. It could be a non-viable pregnancy, but you don't know. It could just be earlier. The best thing is not to cause fear, just positivity and reassurance and close follow-up. So there's a couple different ways you can determine, depending on if it's a Friday, if this person has barriers to transportation. You want to kind of determine maybe doing a serial HCG today and then repeating it again on Monday, have them come back to the clinic, and then follow up with another ultrasound in a week and just confirming that everything is looking well. Second case study, this person comes in for an ectopic pregnancy evaluation. They have come into the emergency department with sudden onset of severe right lower abdominal pain and vaginal spotting. They had a positive pregnancy test at home and a history of previous pelvic inflammatory disease. Third baby, and just very anxious. The ultrasound findings, you do a transvaginal because of the approximate 5-6 weeks gestation based on the last menstrual period, and you note there is no viable pregnancy inside of the uterus directly. You try to visualize the areas outside of the uterus, the fallopian tubes, the ovaries. You notice a complex adnexal mass on the right side consistent with a tubal ectopic pregnancy. There is some free fluid noted in the cul-de-sac. It's highly suggestive that this is a right-sided tubal ectopic pregnancy, given there is no intrauterine gestational sac, the pain, the fluid, the adnexal mass. Emergency surgical interventions are probable. You need to get involved with your collaborating team, your obstetrician, your ER doctor, depending on your facility and the situation of your resources, to get it addressed promptly to help prevent the potential complications of rupture and hemorrhage. Case number 3, fetal growth assessment. This person presents to a routine ultrasound. They have a history of growth, diabetes. They are on insulin, and you want to keep a close eye on the baby, not getting too big. They're 32 weeks gestation. She's a 35-year-old first-time mama, and you're going to do a routine growth ultrasound. And that transabdominal ultrasound reveals a normal, healthy pregnancy, and that the baby is measuring at the 90th percentile. The fluid level was within normal limits. The placenta is posterior, away from the cervical os. Based on the ultrasound findings, you note to have macrosomia because the baby is in that 90th percentile and having gestational diabetes. Reevaluate, talk about the blood sugar monitoring, talk about history, get the OB involved, do serial growth ultrasounds, consider doing an earlier induction of labor to help prevent risk of complications from shoulder dystocia and birth trauma. Also doing some non-stress tests, and continued, maybe you could alternate growth ultrasounds with biophysical profiles based on other comorbidities and history situation. Based on these findings at 36 weeks gestation and poor placenta, low fluid level, decreased fetal movement, most likely you're going to have them immediately go to the hospital for an induction and work closely with an obstetrician for an induction of labor late preterm due to oligohydramnios and decreased fetal movement. I would encourage close fetal monitoring during labor. Otherwise, just expect based on her Bishop score how aggressive you'd get with the induction. Case study 5, evaluation of an ovarian mass. You have a patient that presented 45 years old with complaints of pelvic pain and bloating over the last few weeks. She came into the clinic, has had a history of irregular menstrual cycles. She's perimenopausal at this time and a history of family ovarian cancer. Ultrasound findings: no. Transvaginal ultrasound reveals a complex cystic mass in the right ovary, measuring approximately 8 cms in diameter. The mass demonstrates solid components and septation within the cystic structure. Color Doppler imaging demonstrates increased vascularity within the mass. The interpretations of this ultrasound finding suggested of ovarian neoplasm, likely a complex ovarian cyst with solid components. Presence of septation and increased vascularity raises concerns for malignancy, particularly in the setting of the patient's symptoms and family history. Definitely need further evaluation with tumor markers, considering surgical interventions, biopsy, potential ovarian cystectomy, oophorectomy. Definitely need to get a definitive diagnosis and a management plan. So as healthcare practitioners, you want to get involved all the team that would be the specialist to help with these advanced higher risk situations. Case study 6, the evaluation of uterine fibroids. You have a patient that presented that's 40 years old, complaints of heavy menstrual bleeding, pelvic pressure, reports a history of a fibroid, diagnosed on a previous ultrasound. They're not sure exactly, maybe years ago, you don't have records, you're just going based on that vague history the patient is giving you. You do a transvaginal and a transabdominal ultrasound so that you can get both viewpoints really well. It reveals multiple hypoechoic masses within the uterine wall consistent with uterine fibroids. The largest fibroid measures approximately 10 centimeters in diameter and located in the posterior uterine wall, distorting the endometrial cavity. Color Doppler imaging demonstrates peripheral vascularity within the fibroids. The interpretation of that ultrasound you just did confirms the presence of the fibroid, which is a common benign tumor within the uterine muscle wall. The size and location of the largest fibroid may contribute to some of the symptoms the patient is having with the menstrual bleeding, the pelvic pressure. Management would include symptom control, minimal invasive procedures such as a uterine artery embolization, focused ultrasound ablation, potentially surgical intervention for a myomectomy or a hysterectomy, depending on the patient's symptoms, desire for fertility, and the overall clinical scenario. So most of the point of care ultrasounds, you're going to be the initial management and then get the obstetrician, the surgical provider that's on call covering with you involved in the next steps of management recommendations. Case study 7, adnexal mass in pregnancy. You have a patient that presented 30 years old pregnant with acute onset of right lower abdominal pain, has been nauseous, about 14 weeks gestation, has no other significant medical history. You know on the transvaginal ultrasound a complex cystic mass measuring 5 centimeters in diameter adjacent to the right ovary. The mass exhibits thick septation and irregular borders. Free fluid is noted in the pelvic cul-de-sac. The ultrasound findings are concerning for a rupture ovarian cyst with hemaperitoneum, given the acute presentation, complex cyst mass, and the presence of free fluid in the pelvis. Immediate evaluation and management are essential to assess the well-being of the mom and the baby. Surgical intervention may be warranted if there's evidence of ongoing bleeding or significant hemodynamic instability. This would be another one that you get the initial assessment, you get the paperwork, you get things started, you get involved your higher risk care provider on your team. Case management for number 8, assessment of surgical length in preterm labor. You have a patient that presented 25 years old to the labor and delivery unit, complaints of regular contractions about 3 to 4 minutes apart the last day and increasing with strength and pressure, ends around 30 weeks gestation. She has a history of preterm labor with other pregnancy. They've been doing a close eye on cervical lengths and watching this patient, considered a cerclage, but the patient had declined. The transvaginal ultrasound reveals a shortened cervical length measuring 2.5. The internal os is partially effaced. There is funneling of the cervical canal. The ultrasound findings indicate cervical insufficiency with evidence of cervical shortening and funneling, placing the patient at increased risk for preterm labor. Immediate interventions would be doing corticosteroids, steroids for lung maturation, tocolytic therapy to try to stop the contractions, give her fluids, try to get her to relax. If there's some stress in her life, if she has a history of a vaginal infection, try to get to the root cause. Maybe there's a bladder infection going on to see if you can stop the contractions. Close monitoring a baby. Depending on your facility, if you do preterm deliveries, getting the NICU team involved, or if your facility doesn't, getting this patient prepped and stabilized to transport out. So obviously before you do the ultrasound, you're going to do fetal fibronectin, you're going to do non-stress test, you're going to do a speculum. There's certain things you can do before the ultrasound, but these case studies are more focusing on what would you do with the ultrasound findings based on the symptoms they're presenting with. Case study number 9, evaluation of postmenopausal bleeding. So you have a patient came into the clinic that's 55 years old, postmenopausal, complaining of vaginal bleeding for the last 2 months. She doesn't really have a good story. Sometimes it's painful, sometimes it's not, sometimes it's a few days, then it stops, and then it starts back over. She has no history of hormone replacement therapy. The transvaginal ultrasound reveals endometrial thickness measuring 1.5 centimeters. There's no focal endometrial abnormalities or uterine masses identified. Both ovaries appear atrophic, which is with no evidence of cyst or masses. No gross anomalies noted. The ultrasound findings raise concern for endometrial pathology given the postmenopausal status and having the abnormal endometrial thickening. Differential diagnosis could include endometrial hyperplasia, endometrial polyps, endometrial carcinoma. Further evaluation with endometrial biopsy and or DNC may be necessary to establish a diagnosis and guide appropriate care. This would be another point where you're getting the point of care ultrasound, getting the initial assessment, talking closely with your higher risk care providers that you're on call with as the nurse practitioner, the PA, the midwife covering. Case studies illustrate a wide variety of different situations, and we really need to think about the patient, the urgency, the setting, the team you have, who's on call, what do you have available. When you're evaluating somebody in the clinic versus you're evaluating them in triage, and you're in a level 1 hospital versus a level 3 hospital, your doctor's in-house, your doctor's on call, that's going to make a decision of how quickly you're going to take care of things in each situation. So as an overall conclusion, obstetric and gynecology point-of-care ultrasounds play a pivotal role in helping to do decision-making quickly. For nurse practitioners, PAs, nurses, midwives, it allows us to be able to accelerate our management decisions, especially in those more urgent situations. You want to be able to evaluate real-life scenarios and talk about them with your team. What would you do for gynecological cases you could come up and what presents in the office? Where are appropriate times for point-of-care ultrasounds to be implemented? How do you do the findings? How do you do a growth ultrasound? How do you do a biophysical profile, cervical lengths? Being able to get those detailed calibrations to have accurate diagnostic information to improve the outcomes and help collaborate with the team to get those next step orders, history, situation resolved for the patient.